So gonioscopy is a method of evaluating the interior chamber angle. So this is the normal interior chamber angle. Depending upon the number of structures visible, we classify it into open angle, into close angle, narrow angle. So it can also be used therapeutically for procedures such as laser trabeculoplasty and goniotomy. So there are other means of angle assessment also, such as anterior segment OCT, high frequency ultrasound biomicroscopy. They offer advantages in some aspects of angle analysis, but current clinical opinion suggests they should supplement rather than replace gonioscopic evaluation. So gonioscopy is an indispensable technique that allows the filtration angle to be examined in patients with ocular hypertension or glaucoma. Why we do the gonioscopy? Because the normal angle anatomy is not visible by slit lamp. The angle of interior chamber cannot be visualized directly through the intact cornea, because as you can see here, the light from the angle structure undergo total internal reflection, so it cannot be visualized directly. So it undergo total internal reflection at the interior surface of the precorneal tear film. So due to precorneal tear film, it is not visualized. So when light travels from a medium of higher to one of the lower refractive index, such as cornea to air, this is cornea and this is air, it will be reflected at the interface between the two unless the angle of incidence is less than a certain critical angle, dependent on the refractive index difference. So for the tear film interface, the critical angle is 46 degree. So here the angle is less than 46 degree, so there is total internal reflection occurs. This total internal reflection is used and utilized in optical fiber signal transmission, where this phenomena ensures that light is retained within the core of a cable. Now, because the refractive index of a gonio lens is similar to that of the cornea, so when we put the gonio lens over the cornea, it eliminates the total internal reflection because it replaces the tear film ear interface with a tear film gonio lens interface. So here you can see the tear film ear interface is replaced by the tear film gonio interface. Light rays can then be viewed as they exit the contact lens directly or indirectly. It can be then be seen directly or indirectly. So the father of gonioscopy, Salzmann, in 1914 introduced the gonio lens. Now why we do gonioscopy? In all cases of suspected angle closure, either on the iris shadow test or the Van Herrick test. So then we confirm it by gonioscopy after the iris shadow test or Van Herrick test. To study topography of the interior chamber angle, to assess degree of opening of interior chamber angle recess, to assess the risk of closure on dilation of pupil, visualization of congenital anomalies, classification of glaucoma into primary and secondary, to note the presence and extent of angle neovascularization, assessment of abnormal angle pigmentation, visualization of pseudo-exfoliative material in the angle, to look for post-traumatic angle recession, cyclodialysis, rule out foreign body in the angle after open globe injury, neoplastic invasion into angle structures like ciliary body tumor, diagnosis of epithelial downgrowth, to look for vitreous strands incarcerated in the surgical wound, to view copper deposition on decimate membrane, to study patency of trabeculectomy fistula, to view peripheral laser iridotomy, to visualize the internal ostium of a glaucoma drainage device, to see orientation of haptics of an anterior chamber IOL. The therapeutic indications are laser trabeculoplasty, excimer laser trabeculotomy, goniotomy, gonioplasty, laser goniopotocoagulation, reopening of a blocked trabeculectomy opening, Nd:YAG laser after deep sclerectomy, laser of suture tied around tube of glaucoma drainage device, indentation gonioscopy to break an acute attack of primary angle closure glaucoma. Now, what is direct and indirect gonioscopy? In direct gonioscopy, here you can see the light rays from the angle. They are viewed directly without reflection inside the lens. There is no reflection inside the lens, and here you can see in indirect the light rays are reflected inside the lens. While in indirect gonioscopy, here you can see the rays are reflected. Indirect lenses they use a mirror to reflect rays from the angle, so they exit the gonio lens at much less than the critical angle. So as you can see, the indirect lenses provide a mirror image of the opposite angle, and can be used only in conjunction with slit lamp. So for indirect we need slit lamp. For direct gonioscopy we don't need slit lamp. So direct gonioscopy in direct gonioscopy, the surface of a lens is a dome shape and slanted, so the exiting light strike the contact lens and the air interface. It's steeper than critical angle and they pass through the observer. So and the light from the angle are viewed directly and do not require a slit lamp. They are used when the patient in the supine position, typically under general anesthesia, in the evaluation and surgical treatment of infantile glaucoma. So first we will talk about indirect gonioscopy, in which there are two types: non-indentation and indentation. The non-indentation gonioscopy, the gonio lenses, the classic Goldman lens. So this is the classic Goldman lens. It consists of 3 mirrors, one of which is specifically for gonioscopy, and some gonio lenses have 1, 2 or 4 mirrors. Here you can see a single mirror lens. This is a single mirror lens. These are 1, 2 and 3. Lenses of similar basic structure but with modifications include the magna view. So this is magna view, rich trabeculoplasty, and the hard direct view. These are the other lenses, and this is classic Goldman, one mirror for gonioscopy, the smallest of 3, inclined at 59 degree, is used for gonioscopy. Because the curvature of the contact surface of the lens is steeper than that of the cornea, a viscous coupling substance of refractive index similar to the cornea is required to bridge the gap between cornea and lenses. Gonioscopy should be undertaken in a room where the ambient illumination is low, as pupil size influence the grades of angle closure. So before gonioscopy we should do disinfection. So lenses must be cleaned between the patients to remove any particulate matter and then sterilized. A suggested regimen is to soak the lens in 2% hypochlorite solution for at least 5 minutes, followed by thorough rinsing in a sterile saline, then air drying. It is essential that the examination takes place in a room in which the ambient illumination is low. The size and intensity of the slit beam should be reduced to the absolute minimum compatible with an adequate view. Do not direct the beam through the pupil. The patient is seated at the slit lamp and advised that the lens will touch the eye but will not usually cause discomfort. The forehead must be kept against the headband and both eyes should remain open. A drop of local anesthetic is instilled. A drop or two of coupling fluid like heparomillilose 0.3% is placed on the contact surface of the lens. The patient is asked to look upward and the lens is inserted rapidly so as to avoid loss of the coupling fluid. The patient then looks straight ahead. Indirect gonioscopy gives an inverted view of the portion of the angle opposite to the mirror. Inverted view, so keep in mind. Once the initial examination has been performed and the finding noted, increasing the level of illumination may help in defining the angle structures. When view of the angle is obscured by a convex iris, it is possible to see over the hill by asking the patient to look in the direction of the mirror. So only slight movement is permissible, otherwise the structures will be distorted and a closed angle may appear open. Excessive pressure with a non-indentation lens. So if we give excessive pressure, so a non-indentation narrows the angle appearance. So excessive pressure will narrow the angle appearance. So in contrast to the effect of pressure during indentation gonioscopy, this is in contrast to the indentation gonioscopy. Excessive pressure also causes folds in the cornea that compromise the clarity of the view. In some eyes, suction on the cornea from the lens may artificially open the angle. Awareness of the need to avoid retrograde as well as anterograde pressure on the lens will tend to prevent inadvertent distortion. Next is indentation gonioscopy, also known as dynamic or compression gonioscopy. The gonio lenses include the Zeiss lens, the Posner, this is Posner and Sussman lens. Posner and Sussman lens. This is the slit lamp view of the lens in place of on the cornea. This is Zeiss lens. This is Posner and Sussman lens. There is no need of coupling fluid because the contact surface of the lens has a curvature flatter than that of the cornea. Indentation is performed by gently pressing the lens posteriorly against the cornea. This will force aqueous into the angle and push the peripheral iris posteriorly. Now, if the angle is closed only by apposition between the iris and cornea, it will be forced open, allowing visualization of the angle recess. Here you can see before indentation and after indentation. Now, if the angle is closed by adhesions between the peripheral iris and cornea, which is known as peripheral anterior synecdoche, it will remain closed. Dynamic gonioscopy can be invaluable in helping to define the structures and angles that are difficult to assess, such as an extensive or double highly pigmented Schwalbe line from the pigmented meshwork. Now direct gonioscopy. Here you can see no slit lamp is required. Angle can be viewed directly. Direct gonio lens include Coepi Medical Workshop, Barkan and Swan Jacob. So this is Coepi lens plus 50 diopter lens, barium crown glass or plastic. Gonioscopy is performed with the patient in the supine position. Here you can see. Note that this may deepen the angle. In conjunction with an operating on or handheld microscope can be used, or magnifying loops can be used. The technique cannot be used with a disturbed slit lamp, so clarity, illumination and variable magnification are not comparable with indirect lenses. Saline is used instead of coupling fluid. Here you can see gonioscopy being done under anesthesia using handheld biomicroscope. Here also you can see gonioscopy is being performed under anesthesia. Here you can see gonioscopy being performed under anesthesia using Swan Jacob lens. Pediatric surgical gonio lens. This is Swan Jacob lens. So it is used for the evaluation and surgical treatment of infantile glaucoma, goniotomy or placement of stent in the Schlemm canal. Patient is in the supine position and we need operating or handheld microscope or magnifying loops. So when gonioscopy should not be done? In acute infections, bulla present on the cornea due to raised IOP, post-traumatic eye, pacomorphic glaucoma. Identification of angle structures. Accurate identification of angle structures is not always straightforward, even for the experienced clinician. So the first structure is Schwalbe line. This is the most anterior structure. Here you can see this is the most anterior structure. Appearing whitish to variably pigmented. Anatomically, this Schwalbe line demarcates the peripheral termination of decimate membrane. This is the peripheral termination of decimate membrane and the anterior limit of the trabeculum. It may be barely discernible in younger patients. In contrast, there may be pigmented deposits on or anterior to Schwalbe line, called a Sempowlesi line, especially in heavily pigmented angles like pseudoexfoliation syndrome. It may have a double line configuration when the posterior component may be mistaken for the pigmented meshwork. Next is corneal wedge. It is useful in locating an inconspicuous Schwalbe line. Using a narrow slit beam, two distinct linear corneal reflections can be identified. Here you can see one on the inner and one on the outer corneal surface. The outer reflection will arc around across the corneoscleral interface due to sclera being opaque to meet the inner reflection at the apex of the corneal wedge. Here is the apex of the corneal wedge that coincide with the Schwalbe line. This is the Schwalbe line. This is the Sempowlesi line. This is the apex of the corneal wedge in open angle. So here you can see apex of the corneal wedge. Next is the trabeculum shown by the arrow. It extends from the Schwalbe line to the scleral spur. From the Schwalbe line to the scleral spur. It has average width of 600 micrometer. In younger people, it has a ground glass translucent appearance. The anterior is the non-functional part and it lies adjacent to the Schwalbe line. This is the non-functional part. It has a whitish color. The posterior is the pigmented and functional part. It lies adjacent to the scleral spur It has a grey-blue translucent appearance in the young. Trabecular pigmentation is rare prior to puberty, but in older eyes involve the posterior trabeculum to a variable extent, most marked inferiorly. Patchy trabecular pigmentation in a suspiciously narrow angle raises the possibility of intermittent iris contact. Next is the Schlemm canal. It may be identified in the angle, especially if non-pigmented, as a slightly darker line deep to the posterior trabeculum. Blood can sometimes be seen in the canal either physiologically due to excessive pressure on the episcleral veins with a gonulence, or in the presence of low intraocular or raised episcleral venous pressure. Here you can see. Next is the scleral spur. It is the most anterior projection of the sclera and the site of attachment of longitudinal muscle of the ciliary body. Here you can see. This is the scleral spur. Gonioscopically, it is situated immediately posterior to the trabeculum and appears as a narrow whitish band. Here you can see narrow whitish band that yellows with age. Next is the ciliary body. This is the ciliary body. It stands out just behind the scleral spur as a pink, dull brown or slate grey band. Its width depends on the position of iris insertion, and it tends to be narrower in hypermetropic eyes and wide in myopic eyes. Narrow in hypermetrop, wide in myope. The angle recess represents the posterior dipping of the iris as it inserts into the ciliary body. The angle recess may not be visible in some eyes due to physiological anterior iris insertion, though fixed pathological angle narrowing due to peripheral anterior synecdoche should be excluded. The iris processes, they are small, usually tenuous extension of the interior surface of the iris that insert at the level of the scleral spur and cover the ciliary body to a varying extent. They are present in about 1/3 of the normal eyes and are most prominent during childhood and in brown eyes. The processes should not be confused with PAS. The PAS typically extend more anteriorly and are more substantial. These are iris processes and these are the PAS. Blood vessels, radial vessels at the base of the angle recess are often seen in normal eyes. Pathological blood vessels run randomly in various directions. As a general principle, any blood vessel that crosses the scleral spur into the trabecular meshwork is abnormal. Larger circumferential vessels may also be seen. Gonioscopic grading of the angle. There are different grading systems: shaffer, spaeth, scheie, RBC classification. Dr. Rajendra Prasad, Center for Ophthalmic Sciences. First one is shaffer system. It is a more commonly used grading system. Shaffer in 1960-1962. This system describes the degree to which the angle is open rather than the degree to which it is closed. On shaffer system, the grade 4 refers to a wide open angle. Grade 4, a wide open angle, while in scheie system, grade 4 denotes a closed angle. The shaffer system approximates the angle at which the iris inserts relative to the trabecular meshwork. The iris inserts relative to the trabecular meshwork. Now, if the angle is between the iris and the meshwork is 20 to 45 degree. 20 to 45 degree. The angle is felt to be at no risk of closure. Angle from 0 to 20 degree are considered capable of closure. Angle 0 to 20 degree. So grade 4 is open, grade 3 is also open. So above 20 degree it is open, below 20 degree it is closure. Spaeth considered that available grading systems provided limited information, and he proposed a system that grades the three major features of angle anatomy. Number 1, the level of iris insertion, the width of the angle, and the configuration of the iris. The level of the iris insertion, the first. It is represented by letters A through E. It is described if the iris inserts anterior to Schwalbe line. If the iris inserts anterior to Schwalbe line, it is described as grade A for anterior. A for anterior. If it inserts anterior to posterior limit of the trabecular meshwork, it is grade B. B means behind the Schwalbe line. So in the B grade is if it inserts anterior to the posterior limit of trabecular meshwork, it is grade B. If the insertion is posterior to scleral spur, the iris is grade C. The iris is grade C. C mean in sclera. Insertion into the ciliary body face is recorded as grade D. D means deep. Or grade E for extremely deep. More than 1 mm of ciliary body visible. Angular width is estimated angle between a line tangential to a trabecular meshwork and a line tangential to the surface of the iris about 1/3 of the way from the periphery. The angle is expressed in degrees: 10 degree, 20 degree, 30 degree and 40 degree. Third is the described curvature of the peripheral iris. R for a regular or flat configuration. R for regular or flat configuration. S for steep curvature or iris Bombay. S for steep or iris Bombay. Q for queer or concave curvature. Q for Q or concave curvature. This is concave and this is flat and this is iris Bombay. This is Baker's goniogram on which gonioscopic findings are drawn. The central dark line represents the scleral spur. The three lines outside the dark line represents the trabecular meshwork. The three lines inside the dark line represents the various level of iris insertion into the ciliary body.